What I'd like to overview in the next 15 to 20 minutes is the treatment of the condition of non-obstructive azoospermia, arguably the most severe form of male infertility that we know of. It is a condition where the man has low sperm production, so low that no sperm actually even appear in the ejaculate. The rationale for and development of the technique of microTESE, microdissection testicular sperm extraction, a surgical approach to get sperm so they can be used with IVF, is what I'm going to present here. I'm going to use some slides and graphics to help with that. This YouTube presentation will involve discussion of the surgical techniques, how they were developed, as well as results of treatment. So non-obstructive azoospermia is just that. It is a lack of sperm in the ejaculate because of low sperm production. Azoospermia, a lack of sperm in the ejaculate, can also occur if there is obstruction, normal production with a blockage of sperm flow. Non-obstructive azoospermia can be sorted out in more than 90% of cases by a doctor examining the patient and doing some simple blood tests, such as a hormone blood test for the FSH level. In non-obstructive azoospermia, the FSH level is elevated. The FSH is not the problem, but a man's body is sensing that the testes don't work properly, and the body therefore makes more FSH to try and drive or stimulate the testicle to work more effectively. Techniques that have been used to try to get sperm for men who have non-obstructive azoospermia include fine needle aspiration, using a needle from outside the body penetrating into the testicle. A refinement of that technique is referred to as FNA mapping, and it's an attempt to try to identify the sites where sperm are being made within the testicle. Biopsies, which is a simple removal of a limited bit of tissue to examine what's going on in the testicle, is another approach people have used to attempt to retrieve sperm. And also TESE, or testicular sperm extraction, which is typically done by making multiple biopsies, taking multiple samples blindly within the testicle. MicroTESE, or microdissection testicular sperm extraction, is a more refined approach where an operating microscope is used to identify the areas of the testicle that are making sperm, resulting in very, very limited amounts of tissue removed, and can be done very safely and effectively by experienced practitioners. There has been controversy over the best technique for sperm retrieval, and that's been looked at in some scientific studies. Because non-obstructive azoospermia has abnormal sperm production, it's important to remember that some men with NOA, or non-obstructive azoospermia, have heterogeneity, meaning some areas of the testicle that work differently from others. The testicle is very well organized with hundreds and hundreds of different tubules, each within its own separate compartment within the testicle. And any one of those tubules may work, meaning may produce sperm or not produce sperm. And all that is necessary to be successful in treatment is to find at least one area of the testicle that is making sperm. Then those sperm can be used together with in vitro fertilization and individual sperm injected into eggs to provide a pregnancy. This is a schematic view that looks at what the testicle may look like in non-obstructive azoospermia. These white areas, or seminiferous tubules, are demonstrated, and the ones that are outlined in black represent, at least conceptually, what areas of sperm production look like. The sites of sperm production tend to be very limited in non-obstructive azoospermia. Otherwise, there'd be enough sperm to reach the ejaculate. But the geographical sites, which areas of the testicle work or don't, are not predictable. And therefore, searching through the testicle is necessary to find those sites. When sperm production is present, fortunately, it's usually present throughout the seminiferous tubule. There are some men with non-obstructive azoospermia, like the men with a unique condition called Klinefelter syndrome, where only focal small areas of sperm production are present. Now, studies have been done to look at which technique is better. So these techniques have looked at testicular sperm extraction or multiple biopsies and compared them to microTESE. And basically what you can see is you average together all of the results from the microTESE results, the proportion of men with sperm found is higher than if you do multiple biopsies of the testicle in a blind fashion. Similarly, if you look at fine needle aspiration or TESA, aspiration of testicular tissue, the sperm retrieval rates on average are much lower than if you do multiple biopsies. So multiple biopsies are better than testicular aspiration, and microTESE is better than multiple biopsies for sperm retrieval. Unfortunately, the concept of FNA mapping to find sperm has turned out to be flawed. Blind passage of needles has a limited ability to sample the many seminiferous tubules, the areas that can make sperm, because the aspiration takes just tiny little bits of that tissue. And that's why sperm retrieval is nearly threefold more likely to occur with microTESE than with FNA maps, as shown in those comparative studies on the last view. We practically find when we do microTESE procedures in men who have had FNA maps done previously, that the maps will actually miss the best areas of sperm production that are relatively easy to identify with an operating microscope. We've also seen that fairly extensive scar tends to occur with an FNA map. And we see that when we go in and examine the tissue of the testicle after an FNA map has been attempted. On the other hand, the safety of microTESE has been demonstrated in multiple studies. Clearly, there is less scar, there is less damage with microTESE than other surgical approaches to sperm retrieval. To do microTESE, you actually need to get into the testicle. Unfortunately, we can see where blood vessels are inside of the testicle under an operating microscope when we're in the operating room. That allows us to safely open the testicle and look at the tissue inside. Schematically, when we open the testicle, we're able to then examine the tissues just like was shown in that schematic diagram. Fortunately, this surgery is done by following the blood vessels, which run parallel to the seminiferous tubules, so you can actually open the tissue and look deep within the tissue to examine the areas of seminiferous tubules throughout the testicle. When seminiferous tubules are making sperm, they tend to be larger or more dilated, and they're easier to identify. This is just an example of what it looks like through an operating microscope. You can see that an area here with an enlarged seminiferous tubule tends to correlate to what we see on biopsy as having a tubule with many sperm-making cells and individual sperm. Those tubules all tend to have fewer cells within them. They tend to have a pattern we refer to as Sertoli cell only, and are much less likely to contain sperm. So by focusing just on these areas that are better and taking out milligram quantities of tissue from those tubules, we are able to identify and take sperm that can be used for reproduction with the limited amount of tissue removed. Now, when sperm are present, they're actually inside of the tissue. So we very carefully break that tissue up so that any sperm inside of the tissue can be identified during the procedure. That guides how much surgery needs to be done, what areas of the testicle need to be looked at. We make sure that the tissue is broken up very well by actually running the tissue through a tiny little needle called an angiocatheter, and that's a fairly straightforward process to give us the best chance of identifying any sperm that are present. We also look at those samples in the operating room using what's called a phase contrast microscope and can identify sperm that are present within minutes of processing that tissue. We use an experienced embryologist, a technician who works on the IVF team, and is able to identify sperm that can be used for IVF and single sperm injection. We have done this microTESE procedure in over 2,800 men. We usually do the surgery together with IVF for the female partner, and typically that sperm retrieval surgery is done on the day before the female partner's egg retrieval. We always double check a semen specimen before doing that surgery to be absolutely sure that there's no other sperm to work with, even if prior semen analyses have demonstrated no sperm at all. By doing the retrieval the day before the egg retrieval, it gives us plenty of time to process those tissues and to find any rare sperm that may be present. That also allows us to keep the sperm fresh. That sperm tend to acquire some motility when they're sitting in media, and that allows us to have the best chances of fertilization of eggs and pregnancy. For first-time procedures, meaning for men who have not had any other attempts at sperm retrieval for non-obstructive azoospermia, we find sperm 54% of the time. Per injected egg, 45% of those eggs will fertilize. And on the first try, the chance of a pregnancy, meaning a heartbeat that can be seen on ultrasound 6 weeks later, chance of a pregnancy is 40% once we identify sperm in the operating room. Unfortunately, it's difficult to predict who is going to have sperm before surgery. Even hormone levels like FSH levels, stratified here as being in the lower range, which is closer to normal, or FSHs that are markedly elevated, again, signifying that the body is recognizing that much of the testicle does not work normally. These FSH levels really don't predict the chance of sperm retrieval. Some clinicians, some even expert urologists will say, well, if an FSH hormone level is very high, as in this group of patients over here, then there's no way you can be successful. But what you'll see is our results have a sperm retrieval rate that's very close, whether the FSH is high or low, because all we need is a single area of the testicle to work, and that's enough for us to go in and identify and find sperm to use for reproduction. What is very important is the extent of search through the tissue. If you just look at the initially open testicle, you'll find sperm almost 60% of the time, but you need to look deeper within the tissue the remainder of the time to find sperm. And the ability to do that sort of search and do it safely and carefully is critical. There is a learning curve to performing this procedure. It's difficult in your first several hundred procedures to get optimal results. We've also looked very carefully and followed men after they've had the surgery. And in this case, we're looking at testosterone levels before surgery, 1 to 3 months after surgery, 12 to 18 months after surgery. And what you can see is that even though there is a slight decrease in testosterone levels initially after surgery, that comes back to baseline in almost all cases. The risk of having low testosterone from a microTESE procedure is very small. It's less than 5 to 10% on a first procedure. So what we've shown is that non-obstructive azoospermia can typically be identified by a doctor examining men and by finding the blood test, the FSH hormone level, to be markedly elevated with low testicular volume, and that will make the diagnosis for over 90% men with non-obstructive azoospermia. Evolution of the surgical sperm retrieval treatment was made possible by serial clinical observations, by treatment of thousands of men, by observation of patients who were treated elsewhere, and we learned what sort of mistakes could be made in sperm retrieval and applied that to make this surgical technique better. We use the operating microscope to define the anatomy and follow the normal anatomy of the body, but there is still a long learning curve to effectively performing this procedure and getting the best results. So microTESE has been demonstrated to be the most effective and safest procedure to get sperm and allow treatment of men with non-obstructive azoospermia. In summary, then, I hope that we've provided information on how you can treat non-obstructive azoospermia, how we can successfully go in with microTESE surgery and allow sperm to be found, allow those sperm to be used together with IVF for a female partner to allow effective pregnancies. The delivery of children so far has been very effective. The health of the children is comparable to what we'd see in the general population or to see in other couples who have to go through treatments like IVF. So treatment for non-obstructive azoospermia is possible for most men who have this condition, but it needs to be done at a specialized center with expertise in the surgical treatment and tight coordination of that care together with IVF. Thank you for taking the time to watch this information.